Hello, everyone, and welcome to this webinar. My name is Emily Robson. I use she, her pronouns, and I am the Transformation and Community Partnership Manager at the Foundation for Healthcare Quality. As we get started, I'd like to begin with a land acknowledgement. I'm speaking from the unceded land of the Duwamish tribe. We acknowledge the Native people, past, future, and present, who have cultivated the land within Washington State, their knowledge and practices that support the health of the people, animals, plants, and land in our area. I will pass it off to Ginny to help start the webinar. Thank you.
Thanks, Emily. And welcome everybody to part one of three parts around committing to equity. Today, we are committing to action. We're going to talk about facilitators and barriers to achieving equity. I'm Ginny Weir. I use she, her pronouns, and I'm the CEO of the Foundation for Healthcare Quality. And along with our co-host organizations, the Washington Health Alliance and Comagine Health, we are grateful for all of you joining us today. So next slide. You are all on mute and will be throughout the webinar. Please add any questions to the Q&A box at the bottom of your screen as we walk through our agenda, and any technical issues into the chat box. Recording will also be accessible after the meeting through our YouTube channel, so watch out for a follow-up email. So our intention here today is really to create a shared understanding of health equity initiatives within and Washington State and really across the country. We're hoping to analyze differences and similarities between initiatives we talk about for aligning work really as our top goal, describing how all of our sectors contributes to health equity, naming at least one initiative promoting health equity efforts, and really want to walk away from today with one action you or your organization can take to help further health equity. Next slide. So our Centers for Disease Control and Prevention defines health equity as every person having the opportunity to attain their full health potential, where no one is disadvantaged from achieving this potential because of their social position or any other socially determined circumstances. Ralph Waldo Emerson also said, the first wealth is health, that these bodies through which we move through the world are our primary enablers of opportunities and really depend on our surrounding environment to mitigate barriers. And acknowledging this role of our surrounding systems, the White House recently defined equity as the consistent and systematic, fair, just, and impartial treatment of all individuals, including those who belong to underserved communities that have been denied such treatment, such as those who are Black, Latino, and Indigenous and Native American, Asian Americans and Pacific Islanders and other persons of color, members of religious minorities, lesbian, gay, bisexual, transgender, and queer persons, persons with disabilities, persons who live in rural areas, and persons otherwise adversely affected by persistent poverty or inequality. So we're here because we want to do something, right? I think that's kind of our main motivating factor. Our BRIE Collaborative has added equity as a core goal to our mission statement. Health equity is both a core value of our Foundation for Healthcare Quality and a strategic goal across our care outcomes assessment programs, our BRIE Collaborative, our Patient Safety Coalition, and Smooth Transitions. We've held a series of internal equity meetings to spend time learning and reflecting on who we are as people, as employees, and how we show up within an organization. And if our audience has not already, I encourage everybody to Google Loretta J. Ross's TED Talk and learn how to call people in instead of calling them out. We are also working on building an equity action collaborative through which to implement our BRIE guidelines across our healthcare ecosystem, and more on that will be coming later. Next slide. So today we are very lucky to be hearing from a fantastic group of people, all whom I admire. Dr. Huynh, the Health Equity Director at our HCA, Dr. Josephine Huang, Medical Director of Commercial Markets at Premera Blue Cross and a Foundation Board member, Dr. Joseph Huang, Medical Director of Commercial Plans, Physicians of Southwest Washington and MultiCare Connected Care, and Amy Laurent, Global Health and Research Manager at Microsoft. Next slide. So today I am joined by my esteemed colleagues, Dr. Drew Oliveira with the Washington Health Alliance, and by Sarah Holopick with Comagine Health. All three of our organizations are dedicated to improving the quality and value of healthcare delivery and are collaborating on this series to dive into equity more deeply as a dimension of quality. An equity lens is our tool to really build a more equitable healthcare ecosystem. And I look forward to understanding and reflecting around how our partners on the table today are centering equity in business, in healthcare delivery, and in their day-to-day. So Drew and Sarah, I will welcome you to our virtual stage. And Drew, I'll turn it over to you for some opening words.
Well, hey, thank you. We can't really talk about quality unless we're really talking about equity, and equity is going to mean something different in every community. We're seeing in the data that we just released that where you live matters, but where someone lives in Washington, those issues, those barriers, those inequalities, if you will, in terms of using and accessing the system are going to be different. It's going to be different if you're in rural Washington versus South King County. And so developing sort of the skills and the tools and really the right framework in terms of how do I evaluate my community so I can identify those barriers that exist, and then how do I take action to address those? I think that's the work that we need to be doing. Otherwise, we're never going to get to health quality for everybody.
Well said. And thank you for agreeing to speak after your fabulous webinar earlier this week. How about you, Sarah?
Yeah, for Comagine Health, we're a national nonprofit healthcare consulting company with the vision of working with our partners to improve health and create a better healthcare system so that people and communities will flourish. And within that vision, our board sets 4 strategic areas of focus for us, one of which is health equity. And the ways that our different departments address that strategic area of focus within the vision is a little bit different. Our care management, our data solutions, research and evaluation, and system-wide quality improvement departments all have areas of work that focus on helping to achieve health equity for specific populations, those with Medicaid as their payer, tribal members, migrant farm workers, the elderly, more. But one thing that we are doing consistently that I'm actually pretty excited about is pursuing high quality data sources and applying analytic best practices to ensure that our work is data driven and addressing the drivers of those health inequities for all that experience them. So I think that a data driven approach using both qualitative and quantitative data that is high quality is a good step in the right direction. So looking forward to the presentations today.
Thanks, Sarah, Drew, and Jenny. We're going to move on to our first speaker is Dr. Huynh from the Washington Healthcare Authority, who is the Health Equity Director. So I'll pass it over to her.
All right. Good afternoon, everybody. Just checking to make sure you can hear me okay. Good. All right. Yes. Thank you. So I'm Dr. Huynh. I go by Quinn, she, her pronouns. I'm the Health Equity Director for the Washington State Healthcare Authority. I'm a family nurse practitioner by training and an academician, having spent most of my career in underserved communities. Although HCA has always pushed to advance health equity, the concept or even vocabulary of equity is fairly new in this country, especially in government, and it needs a lot of development to ensure that it brings our existing work to that next stage for a healthy Washington state. Next slide, please. I'm getting over respiratory illness, so I'm going to have a little bit of a frog in my throat. I apologize. So the Washington State Healthcare Authority, I want to speak a little bit about who we are. We are responsible for purchasing healthcare for 1 in 3 non-Medicare Washington residents. So this includes all programs under the Apple Health, which is our Medicaid plans, the Public Employees Benefits Board, and the School Employees Benefits Board programs. This makes up about 2.5 million Washingtonians. Additionally, we provide behavioral health services for all 8 million Washington residents. Next slide. Our approach to healthcare purchasing is transformative, whole person care, and it is informed by evidence. We transform care through pushing for better care and outcomes at a lower cost. We do this through integrating physical and behavioral health services. And we're using data to inform our work in our purchasing decision. Our annual budget is around $17 billion US. So it is imperative that we must be good stewards of this funding. One way to do this is to ensure that health equity is at the center of our vision, mission, and strategic plan. Next slide. So what is health equity? Health equity means that everyone has a fair and just opportunity to be as healthy as possible. And this requires that we remove obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. Excuse me. So this language is based on the Robert Wood Johnson Foundation's definition of health equity. So you can see the picture on the right here. It speaks to the difference between equity and equality. Equality is where everyone, or in this case, every plant gets the same environment, same weather, same soil. This can result in a happy cactus, a semi-okay flower, and a kind of dying plant. Whereas in equity, each of these plants gets the environment that best fit their needs, different amount of sun, rain, and soil quality so that they can all thrive. That's what we need to do for Washingtonians, to provide an environment in which everyone has the opportunity to be as healthy as possible. On the next slide, I want to just take a moment to acknowledge the timeline of our equity work. In 2013, we launched the Home Health Program in collaboration with DSHS. In 2015, we stood up the Accountable Communities of Health. In 2016, we implemented the Medicaid Transformation Project, and that one is derived from the Affordable Care Act. In 2018, the Division of Behavioral Health and Recovery became part of HCA, really focusing on that behavioral health piece for all of Washington. In 2019, we launched our School Employees Benefits Board coverage. And in 21, we created the first Health Equity Director position, and that's my position. Last year, we launched the Pro-Equity Anti-Racism work in conjunction with our renewal of the Medicaid waiver. Not listed on this timeline is last month, President Biden issued an executive order called Furthering Advancing Racial Equity and Support for Underserved Communities through the Federal Government. This is really important because it emphasizes the needs for changes in governments at all levels. Next slide. So how do we support health equity at HCA? Next slide, you're going to see that historically, HCA has always done equity work because Medicaid is a tool to support underserved populations. However, there was no clear, standardized, and unified process and no dedicated FTE for health equity. So by formalizing the work and creating FTEs, HCA strives to build a new infrastructure. In 2021, we began creating these new positions called the Health Equity Liaisons, where each of our 18 internal divisions must have 1 or 2 people who serve in this role. And these Health Equity Liaisons serve as a bridge for their own division to connect our health equity work across the agency. They are responsible for communication, training, and alignment of their division's efforts, and they also serve on various committees that I've created for them. Next slide. So by the end of 21, we added a new sentence in all of our employees' job description to say that HCA employees will apply an equity lens to their work, which may include, but is not limited to, all analysis of core business and processes. Alongside that, we created the Health Equity Toolkit that helps our staff to apply this equity lens to design and evaluate all of the policies, programs, and the services that we do. This includes identifying and addressing disparities during legislative session, where we give input on hundreds of bills. Adding this equity lens has shown a difference in how we evaluate and support bills, and then leading to a change in our services and programs. Next slide. As part of the infrastructure building, we also created an internal equity inventory and dashboard where we collect and we track and view all of the equity related work taking place within our agency. We currently have a database of nearly 100 initiatives. HCA staff are able to access this database and research past and existing work so that they can find opportunities for collaboration and alignment. Additionally, we also created the Collaborative Community for Health Equity, where all HCA employees are invited to attend once a month to learn and share best practices and sharing resources that they have. We are currently in the process of designing a series of health equity training modules that will launch in a couple of months. Next slide. I'm going to change gear a little bit and talk about the pro-equity anti-racism work. In March of 22, Governor Inslee issued the Pro-Equity Anti-Racism Executive Order, aka PAIR work. This requires all state agencies to have a plan to become pro-equity and be anti-racist. So one of our accomplishments was the establishment of the PAIR Community Advisory Team, PAIR-CAT. This team is comprised of community members who advise our internal work. We want to engage with and hear from these underrepresented and underserved communities. That includes Black, Indigenous, and people of color, non-English or English as a second language speaker, immigrants, refugees, LGBTQ+, and many other communities. We hold regular meetings with them to share information and discuss high-level strategies. We want to get to the involve and collaborate stage where our work is co-led and power is shared between government and communities. On this next slide, you're going to see that the PAIR and PAIR-CAT teams work together and identify 4 key areas known as work streams. We are focusing on these in 2023. The work streams are community engagement, which is not to be mistaken for stakeholdering, data equity strategy, leadership and operation strategy to enhance health equity, and the 4th one is workforce. This is not only focusing on our internal HCA workforce, but also looking at Washington State healthcare workforce as a whole. We are exploring ways to create a health workforce to serve all of Washington, especially for rural and underserved populations. So let's move on to the next slide where we talk a little bit more about external work, because all of the things I've mentioned are internal infrastructure building that will stoke some of the external results. HCA is making intentional efforts to address health equity and diversity, equity, inclusion, and belonging, so DEIB. We do this through applying the lens of equity in all of our work. This includes the STEP and PEP programs, the Medicaid programs, the way that we are redoing our Medicaid transformation waiver renewal, our prevention, treatment, and recovering programs in behavioral health, value-based purchasing, even in the way that we procure the managed care organizations, among many other things. Next slide. Externally, we're heavily involved with other agencies and national partners. I serve as a council member on the Governor's Interagency Council on Health Disparities. This council is responsible for identifying priorities and creating recommendations for the governor and the legislature to eliminate health disparities by looking at race, ethnicity, and gender impacts in Washington State. I also serve as a council member of the Department of Health Health Equity Zone. The Health Equity Zone is there to create collaboratives that centers on local geographic bound needs, the assets and solutions to address health disparities and poor health outcomes. And then I last year created the Health and Human Services Interagency Equity Collaborative. This includes 6 different organizations and agencies. We are leading this group to review healthcare workforce, data equity, and community engagement strategies. And then, of course, all of the work with BRE and with FHQC, as you see here in this meeting. Together, all of the work that we do with our external partners help us to come up with best practices and provide recommendations to state Medicaid agencies in all 50 states. So in a nutshell, on the next slide, you'll see that HCA focus on 4 key areas as part of our equity strategic plan. We focus on supporting new and ongoing work. We align our agency efforts. We innovate equity infrastructure internally, and then using that to leverage existing work that can serve all of Washington. Next slide. So when we align equity strategies between the 4 key programs in our agency, these 4 programs are Medicaid, behavioral health, and the public and the school employee benefits program. We want to be sure that the learned lessons in equity within each of these programs will be shared and best practices are elevated so that we can synergize our efforts. Since each of these programs receive different funding and are beholden to different regulations, both at the state and the federal level, it's sometimes easy to become siloed. By threading that needle on equity through all these programs, we hope to have better alignment. Next slide, I want to talk about some examples of initiatives that address social determinants of health that we are working on. So we're identifying needs through MCO screenings, we measure disparities in quality measures, billing guidance for health-related social needs. We embed equity through financial incentives for, like for example, we require certain quality metrics to be met in order to receive that financial incentive. Next slide, you'll see that we also cover services like transportation, interpreter services, health homes. Most recently, we have worked on foundational community supports for housing and employment, food security, and medical respite. Other SDOH initiatives is investment in core infrastructure such as the Community Information Exchange system. This is a system where, say, patients can sign up for one service, but they will be notified if they're also qualified for other services. This relieves some of the burden on community members who must do the extra work and research to get these services. An example of how we will use CIE is part of our Medicaid transformation project. We are creating a community hub. The community hubs will use CIE technology and resource and referral processes to support that coordination when we coordinate the patients and clients with connection to community resources. Another SDOH initiative is our equity investment in our Medicaid waiver, where we are working to address issues by investing directly into the system and the communities. Next slide. So we understand that we must work differently in order to create different results. So how are we going to address that? Next slide. So we must center DEIB at the state Medicaid agency level. We know that sometimes policies may be well-intentioned, but end up not achieving the predetermined goals. We also know that communities most impacted are often not included in conversations. So if we want different outcomes, we must do things differently. Here's the challenge. Our system was built without intentional equity work for so long. Now we need to re-examine that system and not just remodeling it, because that's not going to be enough. Instead, we must dismantle some of those existing infrastructure, which requires time, energy, resources. I mean, a lot of resources, and we know that resources are finite. Since equity work is fairly new in government work, we still don't have those resources readily available. This is a big barrier. Another barrier is the power shift. It can be scary. We don't know the power that we have until that power is questioned and removed. Government is inherently powerful. We need to shift that power and elevate community voices. This is another barrier. And finally, government must make the commitment to address health equities and health disparities. That is to say, we must change our culture and infrastructure. We can have all the equity strategies in the world, but remember, culture eats strategy for breakfast, lunch, and dinner. So we must make that commitment to create a culture shift to advance health equity. On my last slide, you are going to see that equity takes time. This is my call to action to end my presentation. I ask that we must act together and we must act now. However, Yoda, the wise one, once said, patience we must have. And so because we spent centuries building the system, it will take more than a few years to redesign it. Thank you for having me today, and I look forward to more conversations.
Thank you so much, Dr. Huynh. We'll now move on to our next speaker. And as a reminder to participants, if you have any questions for our panelists, there is a Q&A box at the bottom of your screen, and we welcome you to input any questions you have. And at a later part in the presentation, we will hope to get to them. So now we'll have our next presenter, Dr. Josephine Young, speak. She's the Medical Director of Commercial Markets at Premera Blue Cross. Dr. Young?
Great. Thank you so much, Emily. And Dr. Huynh, I love that last slide that you have. I mean, So much urgent work to be done, but there is patience needed, and it's definitely going to take us time. So good afternoon, everyone, and thank you for the opportunity to be here with you all today to share ideas and build partnerships about improving health equity in our communities. I'm Josephine Young, use, she, her pronouns. I'm a pediatrician by training and as medical director of commercial markets here at Premera. I work closely with the HCA and large employers such as Microsoft and others in Washington and Alaska locally and on a national basis. In addition, as a board member of the Foundation for Healthcare Quality, I'm especially excited to be a part of the panel today. It is clear that racial disparities in health outcomes are unconscionable and unacceptable, and yet they continue to occur at an alarming rate. This is why the Blue Cross Blue Shield Association and Blues plans across the country came together to commit to making meaningful change and address health inequities. We recognize that this is a complex global issue that cannot be solved by just one organization, and it requires that all partners are committed to addressing these issues at a systemic level and in a systematic way. As much as we all want to move very quickly in this process, we recognize that it will take time. How and where members access their healthcare in local communities can and do look different depending on where they live and work. As has been said many times before, one's health outcomes should not depend on their zip code. Before I focus on specifics about our work at Premera within the local community, I want to talk about what this looks like on a national level. Next slide, please. The Blue Cross Blue Shield Association has a local presence spanning every U.S. zip code and includes about 1 in 3 Americans being covered by a Blues plan. This gives the plans a unique view of the healthcare challenges and opportunities that at a community by community level at the heart of where care is delivered. Across the country, Blue Cross Blue Shield Association has 34 highly successful teams of innovators and problem solvers, each putting their best talent forward to solving healthcare's most pressing problems with a unique local perspective. Because we're local, we're able to quickly test innovative solutions and determine what works and what doesn't. Because we're part of a national association, we have the infrastructure needed to share proven innovations and learnings across the system. All of this is integral to BCBSA's National Health Equity Strategy, which intends to change the trajectory of health disparities and reimagine a more equitable healthcare system through close collaboration with providers and local community organizations. The strategy includes collecting data to measure disparities, scaling effective programs, working with providers to improve outcomes and address unconscious bias, leaning into partnerships at the community level, and influencing policy decisions at the state and federal levels. The association has also convened a national advisory panel of doctors, public health experts, and community leaders to provide guidance. Specific Blues plans will develop strategies that align with this work. Each one is tailored to drive the most impact and change in their local communities, with focus on 1 or more health conditions that disproportionately affect people of color, including maternal health, behavioral health, diabetes, and cardiovascular conditions. Robust, accurate, and quality data is foundational to driving healthcare quality. The Blue Cross Blue Shield Association is leading the effort with equity and industry partners to seek national industry standardization around the collection and ethical and transparent use of equity data. This last point is especially important because at the heart of collecting this data accurately is the trust needed for the data to be used responsibly, ethically, and transparently. This is a tall order and part of what takes more time at this stage of the work. Next slide, please. Now let's take a look at how Premera and other Blues plans are taking this national strategy and customizing it for our members. Our health equity program at Premera is designed around our purpose to improve customers' lives by making healthcare work better. As you all know, health equity is not only about making sure that everyone has equitable access to quality, affordable healthcare, but also ensuring the resource fit a community's specific needs. A fair healthcare system can and should improve health outcomes and quality of care and contribute to the elimination of racial and ethnic health disparities. Through this lens, we at Premera adopted our health equity purpose at this point in our multi-year strategy to increase equitable access for Black Washingtonians, Alaska Natives, and rural customers to improve their behavioral health and hypertension health outcomes. Next slide, please. As we moved forward in 2022, we ensured our health equity work remained grounded in the objectives set forth for behavioral health and hypertension, with the former being the primary focus since behavioral health work was further ahead at Premera. Last year, we established a health equity team within Premera's quality program. 2 new full-time employees were hired to help manage, measure, and track the execution of the health equity strategy. They have education and experience in and around public and community health, project management, group facilitation, and grant writing. Both work cross-functionally with leaders across Premera to ensure the execution of the health equity strategic plan. Also want to highlight here that included within our health equity strategy is also our own Premera employees who are also members in the plan. We have an extra layer of accountability in our work because we must live the decisions and initiatives that we're putting forward. In addition, we also have an internally focused diversity, equity, and inclusion strategy, which is a key component of our people strategy. There are three pillars and that impact, three pillars and impact statements guide our internal work. Our people, we create a culture of belonging where employees feel valued and celebrated, paying particular attention to those of historically excluded groups. Our culture, we're successful when leadership is dedicated to dismantling systematic barriers and reflect the diversity of our communities, employees, customers, and members. And our leadership, we reflect and connect with the diversity that exists within our markets and our membership. To be successful, we recognize that this work has the following dependencies: ongoing sponsorship and support from leadership, continued funding and resourcing of DE&I initiatives, commitment to engage and integrate DE&I work every day and in meaningful ways, and the flexibility to adjust and modify based on our learnings. And this last point is incredibly important because embedded within the commitment to being a learning organization is our humility and understanding that there is much to learn and we don't yet have the answers, and to exercise compassion for unintended mistakes that will be made along the way, and to hold each other accountable and persisting in a path forward, especially when the work gets hard. So what we've done thus far in this area is we've expanded our dedicated DE&I staff because this work cannot be done only off of the side of people's desks. Introduced new learnings for all employees, including diversity, inclusion, and sensitivity, and minimizing bias. We've also had an emergence of multiple training work groups that have organically grown and developed within an inclusive environment that has tangible support from our internal DE&I staff. I've personally been part of the leadership of our Asian American, Native Hawaiian, and Pacific Islander training work group. We've offered a power dynamics forum for people managers and comprehensive implicit bias training for senior leadership. We've held multiple employee forums and all employee meeting sessions focused on various topics, including belonging, behavioral health barriers for historically marginalized populations, Juneteenth, women leadership challenges, and anti-Asian hate, to name a few. We've also revised our time off policies to add floating holidays, providing more flexibility to employees in using their time off in personally meaningful ways. Next slide, please. For behavioral health, we've had a heavy focus on our partnership with the University of Washington Ames Center to support the integration of mental health services in primary care clinics across the rural areas of Washington and Alaska. Through collaborative care, clinics in the program receive collaborative care training for their providers and have embedded behavioral health professionals within their practices. More than 20 clinics in rural areas of Washington and Alaska have successfully implemented the collaborative care model through this grant. Because of this success, we're expanding our focus on urban areas with high concentrations of Black Washingtonians. We're currently working closely with the UW Ames Center to identify provider groups and clinics within the South King County to participate in the collaborative care model. For provider organization partners who are already deeply engaged in collaborative care work, such as MultiCare, we continue to explore opportunities for further advancement. Next slide, please. Another key behavioral health effort has been our work in developing an intentional and targeted destigmatization campaign focused on potential needs of Black Washingtonians. This work was aligned with a broader mental health awareness campaign that Premera's marketing team developed in partnership with the Seattle Kraken. The Kraken campaign was a general market message, while the health equity program was narrowly focused for our target population. Realizing the importance and necessity for Premera to engage with trusted voices to best reach Black Washingtonians, we developed a partnership with Richard Taylor Jr., an Edmonds, Washington-based mental health advocate and author, to develop content, participate in events, and raise awareness that mental health is just as important as physical health. Next slide, please. Part of health equity is also to increase health literacy in support of empowering individuals to make informed decisions for themselves. We continually look at our member-facing communications through our focus on health literacy, via our Let's Be Clear program, which aims to provide information that is simple and easy for everyone to understand. This writing model ensures that a person can get through the content quickly without having to think about the words themselves, allows the reader to comprehend and retain messaging, and helps to create trust between Premera and the member. The program offers all Premera employees access to tools and letter templates along with a writer's workshop to discuss and practice new ways to effectively communicate through writing. One example related to our behavioral health efforts relates to the understanding that our main Premera.com website is often the first place members will seek out information about their plans, find a provider, and learn about their benefits. As such, it was critical to ensure Premera's mental health resource page reflected the lived experiences of our members, particularly Black, Indigenous, and people of color members. An internal work group was established to audit the webpage, consult with community partners regarding culturally appropriate resources, update the look and feel, and ensure a better customer experience. Updates include a more friendly user experience that ensured information was simple and easy to find as well as understand. Crisis information was front and center. Part of the effort to make information easier to understand was to define terms, types of care, and providers. Also, we wanted to ensure that members saw themselves reflected in the art and photography on the page. This extended to the resources presented on the page as well. This is part of a dynamic process that continues to be assessed and will evolve based on our learnings over time. Next slide, please. Another key part of our strategy and something we know is critical across our work at Premera is to better understand the communities we jointly serve with our providers. To do this, we're working to advance our processes for collecting, storing, and retrieving member and practitioner race, ethnicity, and language, REL, and sexual orientation and gender identity, SOGI data. Through effective cross-functional efforts, we initiated discovery and scoping work for the collection, storage, and use of member-reported REL and SOGI data. Last year, our work centered primarily on assessment of our current system capabilities and storage, along with data governance and ethical usage. As Dr. Huang will also mention, Premera's partnership with MultiCare in this area of data sharing will have broad use in enhancing the member experience and eventual health outcomes. One way that we're exploring use of this data is to inform our predictive modeling efforts to better serve our members in communities of color with more timely and relevant information and interventions. The data collected will fundamentally enable Premera to better inform our health equity strategies for benefit design, medical management, quality improvement, customer service, and claims management, inform our regional member outreach and programming, create more culturally responsive member experiences, and enhance our ability to address social determinants of health for historically underserved populations. Next slide, please. Looking ahead for this year, we're building upon the milestones and learnings from 2022. The health equity team is looking into improving the health disparity gap of our Black Washingtonian, Alaska Native, and rural community populations by conducting an employer-based behavioral health campaign in Alaska as an initial pilot effort, and looking to expand this approach pending its results. Increasing access to behavioral health providers in Washington State through collaborative care models with the UW Ames Center. Monitor the ongoing progress of the optimization of the Find a Doc tool on our website, which will incorporate provider, race, ethnicity, and language information. Diversifying the network in South King County by recruiting more Black practitioners. Conducting a behavioral health outreach campaign for Black Washingtonians, utilizing the Kinwell clinics and prominent figures within the community. And partnering with the American Heart Association and Kinwell to expand the check change control and or release the pressure programs in Washington State, and utilizing prominent community voices to connect members to a Kinwell on-site event. We're also excited to engage large employer group partners such as Microsoft, as well as have ongoing conversations with the HCA and provider partners such as MultiCare to enhance our efforts in relevant markets locally and regionally. Overall, we believe more equitable outcomes result when we connect with members, collaborate with community partners, and model equity ourselves. We, along with other Blues, are approaching our health equity program to best serve all our members, regardless of their employer or health coverage. By closely aligning local work with Blue Cross Blue Shield Association's national efforts, we have a comprehensive strategy to drive meaningful change and ensure equitable access to quality care for all members, no matter their zip code. Happy to take any questions that come up. Thank you.
Thank you so much, Dr. Young. We'll go ahead and move forward with our next speaker. But again, if you have any questions, please put them into the box below. Our next speaker is Dr. Joseph Huang, the Medical Director of Commercial Plans from Physicians of Southwest Washington and MultiCare Connected Care. Dr. Huang.
Thank you so much. I appreciate the opportunity to join this group and talk on health equity and what we're doing around health equity at MultiCare Health System. I'm a family doc, and I'm on our population health team. And as part of that, I've been privileged to work with friends at Premera. And so great to hear from Dr. Young about all the great things that they're doing over there. So in the next slide, for those of you who aren't super familiar with MultiCare, we're a nonprofit, locally governed, community-based healthcare organization. We've got about 12 hospitals and 22,500 employees across the state. Our mission is partnering for healing and healthy future. And you see our vision and values there. And really health equity is for us to a large extent about being who we say we want to be in our values, both to ourselves and our employees and to the communities that we serve. The next slide. We signed up in 2016 to the AHA's 1, 2, 3 for Equity pledge, and really that kick-started a lot of our efforts in the equity realm. And so we formed the Center for Health Equity and Wellness in 2016. We went through a cultural competency organizational assessment and really identified some key gaps that we had as an organization in terms of how we show up internally and for the communities that we serve. The vision for the Center for Health Equity and Wellness is to strive for excellence in partnership with the community and to promote health equity and wellness in the Pacific Northwest. I should mention that I have the privilege of sharing, but by and large, it's the work of others and being led by others, including the leaders of the Center for Health Equity and Wellness. Let's go to the next slide. So our strategic plan for the next handful of years is really centered around these priority areas, including community engagement, understanding our population health data, language access and communication, and culturally competent care. And I'm just going to walk through each of these domains and talk a little bit about what we've done since we first embarked on this journey and what we hope to do in the next handful of years. Next slide. So in the area of community engagement, what we started with was the launching of course, the community health needs assessment that all hospitals participate in, but we also really engaged in community by forming a health equity community advisory board. It comprises representatives from more than 30 community-based organizations in our service area, and those folks advise and provide feedback on some of our health equity related initiatives. We also engage some of our faith-based communities by forming a faith and wellness program that includes things like getting church groups in for education, particularly in areas like cancer screening, where we have significant disparities in our communities. We created and implemented a school-based health clinic in one of our alternative schools that has a diverse, vulnerable student population. And we engaged in a really cool partnership with a number of community advocacy groups in the Tacoma area we called Sister Friends 2.0. And we used community health workers from our partner agencies to help enhance outreach, education, and access for breast cancer screening for African American women. As the pandemic hit, we also implemented a handful of community-based equity-focused COVID vaccine clinics. Again, understanding that there were so many barriers for communities of color, especially in vaccination. We had some very targeted approaches to creating those clinics and where we wanted those to pop up. In this domain, over the next handful of years, we want to do a better job using data to guide our grant-making processes for our partner community agencies. We want to provide better grant writing support to advance community-based health-related initiatives in our underserved communities. Our HECAB really is centered in the West Pierce County area especially, and we want to figure out how to do that in a more scalable way across the state. Where we have communities that we serve. And we want to have more opportunities as well for our patients to be directly involved in the care of their communities as health ambassadors. Next slide. So population health data, of course, could be a massive ocean to boil. And, I think we realized at the outset just how much work we had to do in this domain. We realized that we were so inconsistent in capturing data. And so a lot of the push in the last several years was around just capturing the data consistently in a highly reliable way for REL. And then we implemented in Epic SOGP data collection as well, and made that a standard workflow. We piloted a health disparities dashboard, and we formed a system-wide group for alignment of work related to SDOH. Now there's a lot more work to do in this regard, of course. There are further updates that we need to make in the EHR to reflect state-required data fields. Oh, not fiends, although there are data fiends involved as well, I'm sure. We do want to further build out our health equity and disparities dashboard and really have this data drive everything that we do around quality improvement. We want to further engage the community in identifying kind of our needs and what potential solutions might be. And just again, take a segmented data-informed approach to everything that we do across all of our business units. I wanted to highlight a little bit of what we're doing with regard to data in the context of our Premera partnership on this next slide. And as Dr. Young kind of alluded to, they've done a lot of work at Premera around gathering REL data, just as we have. And so we were really excited in the context of a partnership that we have with them to just share the data that we have. I mean, and we didn't have great mechanisms for doing this, but we checked with our respective privacy and legal teams, and we're like, okay, we can do this. We sent a bunch of flat files over with REL and SOGI data to them, but obviously we know that this isn't a sustainable path forward. And so we've had a lot of discussions surrounding interoperability in many, many domains, right? Ranging from auto authorization to just better line of sight into quality and utilization. But one of the things that we want to make sure is on the table as we discuss interoperability is how we, in a more automated way, share the REL data and SOGI data that we have. And our hope really, again, is to, in the context of partnership, understand what are some shared priority areas for the populations that we have in common. The next slide. I did want to show a little bit of our health equity dashboard. Again, this is still in development, but as you can see, we have some pretty standard, looking quality measures, HEDIS sorts of things. But we've never had the ability to understand how these things look different for different people. And so as you can see on the right-hand side, we've created a bunch of additional data fields to pull in from race, ethnicity, gender identity, sexual orientation, spoken language, and are now able to slice and dice some of these quality measures and identify where we actually have significant differences in populations that we serve. And our hope is as we build this out, we will have much better information about the people that we're serving to be able to inform quality improvement, and quality improvement that specifically dismantles some of the inequities that exist. Next slide. So in the domain of language access and communications, there's some, the fact that we didn't have some of these things, again, is pretty embarrassing. But again, we launched on things like getting qualified by the staff program, adding interpreter vendors that had better video interpreter capabilities, because we all know and love phone interpretation. Anybody who's experienced those knows how ineffective those can be. We create a dedicated patient and family language line to facilitate first contact for patients that have low or no English proficiency. And in this domain, from a communication perspective, I think there was a big, acknowledgement internally that lots of people are doing lots of great work in the system to help promote health equity. But often the community doesn't even hear anything about what we're doing, and our own staff don't know what we're doing about it. And so we're improving a bidirectional communication platform to better communicate what we're doing and to get better feedback from our employees and our community members of what's going on for them. We're working on improving the diversity of our signage and images in our printed materials. and wanting to increase language access in general for all of the patients that we serve. Next one. Finally, around culturally informed care, again, we did that cultural competence assessment and identified significant gaps that helped inform some of the priorities that you see here. We implemented some mandatory trainings related to culturally competent care. Again, there's only so much you could do from a cultural impact perspective from something that people can click through, but it really felt like a meaningful step to really get a much more beefed up version of this training. We also partnered with one of our local advocacy groups to create and implement a mandatory LGBTQIA core competency training. We also added recognition for cultural competency as a major category around our annual President's Awards that recognize excellence in work that's being done across the organization. So in the coming years, some of the things that we want to do are really build further on the trainings that we have related to health equity. And we really want to continue to lean into what we're doing in the LGBTQ plus community, help folks understand within the community what providers might be safest for them, and are really committed to creating a safe space in their clinics for folks to be seen. We're continuing to participate in the Healthcare Equality Index, where we've had good marks historically. And with the next slide, I just want to turn briefly to some of the things that we're doing internally with diversity, equity, inclusion, belonging, and talk a little bit of our belonging journey. Again, it's over the last few years, I think there's been really, I think, a calling to account internally on what are we doing as an organization to promote DEIB for ourselves and for the people who comprise MultiCare. And so we created an advisory board comprised of employees that is open on a rotating basis. Our philosophy for this group is that all people are valuable without regard to who they are, whether from how they show up, what they think. That all patients are deserving of care that's high quality and equitable, and that our team members should be folks who really are aligned with their mission, vision, and values. And so, again, in creating this internal group, we've also hired additional staff as part of our HR team to engage with the people that comprise MultiCare to understand what their actual lived experience is as employees and what their priorities are for us to work on as an organization. I will say that this is, again, one of those areas where this is just cracking open the door can be almost more frustrating than not acknowledging that this is an issue at all, because there's just so much that needs to be done. And I'll say that, folks that have served on the advisory board have been frustrated by the pace of change. So there's so much more work to be done, but I think we've been very intentional about trying to create some internal structures to really be serious about holding ourselves accountable to change internally as well. So with that, I think that's probably enough for us to share, and I look forward to our shared conversation as a panel.
Thank you so much, Dr. Huang. Our next speaker is Amy Laurent from the Global Health and Research Manager from Microsoft. So I'll pass it off to her.
Hello, everybody, and thank you for having me here today. As I said, my name is Amy Laurent, and I'm a Global Health and Research Manager here at Microsoft. Next slide, please. Thank you. So our position is a little bit different from some of the people who presented because we're a large healthcare purchaser in the private space, particularly in the Puget Sound. As a purchaser, some of the things I'm going to talk about, I'm going to explain a little bit about some of the health plans that we have here, some of the rules and regulations around what can be implemented, because that has influences on what can be done. And I also am going to talk about the commitment to equity and how we are using data to understand more about equity within our very diverse and multicultural population. So Microsoft has been committed to equity and diversity as a company for quite a while, and employees are tasked with considering diversity, equity, and inclusion across all of our lines of business. All employees have required annual training. And so when we think about equity around health and access, many times like the traditional public health lens of social determinants of health is thinking about, access to care, access to health insurance, income, education, quality and affordable housing, as many of the other panels had talked about. But even in a well-resourced population, we're still seeing some of those differential outcomes. And so being able to identify and address these issues is a real important component of being able to improve health equity. And one of the other ways that Microsoft can influence is through the purchasing power that we have. If there are requirements that change, some of those standards of care can shift, which when, they're talking about like raising all boats. And when in some particular markets also, other employers may match some of the suite of benefits that Microsoft offers. And besides just relying on the clinical outcome data, we also feel like it's important to give the employee experience a voice. So it's matching some of the qualitative and the quantitative data. We are looking at tools and technology to drive change, and we are partnering with some communities across various areas of Microsoft to improve equity. And some of those examples that fall outside of this space are around access to broadband, which can have implications around telehealth or ability to work at home. We partnered with Public Health Seattle King County around a community vaccine clinic in the Puget Sound. And the AI Health for Tools have some aerial-based measurements of social determinants of health that are available for people who may not have easy access to that data otherwise. And we also strongly believe that the investment in health employees now bear out over the long term, and that the health plan design can influence equity. Next slide, please. And health equity issues don't exempt Microsoft just because we're in the tech sector. And it's important for us as an employer to continue looking at equity issues. We're looking at around engagement and outcomes, including just beyond our healthcare plans, but looking at the full suite of services that Microsoft offers. And we're expanding our ability to do that in a more rigorous way, working with our suppliers and our employees. We know that at the overall population level, disparities remain even after you adjust for social determinants. And as I said, we're starting to look at our data more fully to really understand what patterns are occurring and to talk with suppliers about how to address issues that might arise. It's important for our populations to have culturally appropriate care and to have providers that are representative in the network. And working hand in hand with suppliers like Premera, who have similar commitments to equity and access, that really helps us to be able to address some of these concerns. And in our benefit program, we think about like how you can be inclusionary and what benefits need to be included. And our plans include opportunities for individuals who can't get care within a specific radius for travel reimbursement. And we also focus on transgender, the LGBTQIA, and maternity and fertility as some of our specific programs. So one of the challenges that Microsoft has is that as a private industry, our primary plan falls under ERISA, which is the Employee Retirement Income Security Act of 1974. So it's a federal standard that is overseen by the Department of Licensing. And it has rules and minimum standards that are set for these programs, primarily for health plans and retirement. And so the challenge is that sometimes the rules around this can prohibit creativity and how we can address care improvements. I'll talk a little bit more about this in a moment, but is a federal process, like you need to be able to amend it in order to be able to change the rules. And some of the major amendments I've included are on the slide, things like HIPAA or COBRA for continued insurance coverage, the Mental Health Parity and Addiction Equity Act, or the Affordable Care Act. These were all amendments to ERISA that allowed changes in the systems. But ERISA currently does not have any specific requirements around overall health equity or social determinants of health. Next slide, please. And so Microsoft employs over 100,000 people in the United States. And most of our Puget Sound employees participate in our HDHP, which is our high deductible health plan, and that's through Premera. And if people aren't, just to kind of give you some boundaries around like what a high deductible plan is, it has to have a deductible of at least $1,500 per individual and $3,000 per family, but it can range all the way up to $7,500 per individual or $15,000 per family. One of the ways to address some of these large expenses is that there's an opportunity to have a health savings account. So employees can add money up to a certain limit into a tax-free, a federal tax-free account that can be used to pay for some medical expenses. And recognizing that this is a large deductible, Microsoft fully seeds the amount that can be saved for employees below a certain pay grade to help with equity. Part of the reason that the high deductible health plan is useful is because people can decide, like, is the deductible increase, people can decide how they want to engage with services. But there is a tightrope of trying to figure out like what is the appropriate use of services, but also making sure that individuals are able to receive needed and necessary care, and particularly around management of chronic health conditions and around prevention. We also have an accountable care organization called the Eastside Health Network. And the accountable care organization is coordinated care around a primary care provider and has hospitals and other health professionals in it. And it's largely centered on the east side of Lake Washington. Because of the way that this is able to be modeled, employees may be able to understand their medical expenses a little bit more, primarily because we can have some different options. So, for example, we have a maternity care bundle, so people can understand how much it would cost to have a traditional, non-complicated delivery. And so there's an amount that can be seen for the accountable care organization, but it's hard to predict for a high deductible health plan because of where somebody may be in terms of how much deductible they've paid or where, and because the deductible resets at the beginning of the year. We also have some individuals who are in our health management organization for Kaiser Permanente, some in Washington, but primarily in California. Next slide, please. As I mentioned, like ERISA rules can limit the creativity for equity. The preemption prevents state flexibility. And so like when we think about like how we partner across Washington state to address care and equity, because we have to meet these minimum standards, or there may not be the appropriate flexibility for us to address situations. That's one of the challenges that we have. And as a good example of that, like prior to COVID, telehealth wasn't considered to be eligible for pre-deductible coverage, and so people would have to pay for it. Even though telehealth can help to lower the cost or improve access, we weren't able to include it. But emergency amendments to ERISA allowed for telehealth to be covered, but it isn't yet a permanent rule. There's still some legislation that is pending that may make it, but we'll see where that falls. And as I mentioned before, like it's challenging to understand like what can be covered and like what your costs are. So the transparency of something may be more challenging. And with the ACO maternity bundle that I mentioned before, that as an innovative approach, that isn't something that we can do with a high deductible health plan. Next slide, please. And as other panelists have mentioned, like the trust and transparency is so important for this work. The data that we're dealing with is data for our employees, and we have a lot of commitment to transparency and also being able to protect the data as much as possible. We're continuing to engage with employees and suppliers to understand the effects of our offered programs and services. We have large employee resource groups that partner with us, and we can understand the impacts of some of the programs and services, and it also provides valuable insight for action. One of the examples that we have a family employee resource group, or ERG, and when the pandemic hit, there were some discussions around like what's needed, and that helped to drive solutions for families with young children. When we had the Mpox outbreak that was occurring late last year, we worked with the GLEAM, the Gay, Lesbian, Bisexual, and Transgender employees at Microsoft ERG for information dissemination and support. So there are a lot of elements that will allow us to be able to interact with our populations and understand more about what their needs are and to help drive outcomes. We're working to harmonize across our suppliers. So looking at like what are our key performance indicators, what do we have in our particular contracts, and to improve the type of demographic information that's captured. As other people were talking, like sometimes in some of the systems that information hasn't routinely been either captured or isn't part of the information that is aggregated together for us to be able to look at data in the ways that we would like to. And we're working on developing a robust evaluation program for our services. And so we look forward to being able to share out the learnings of the things that we are experiencing. Some of the other things that Microsoft are doing, we have some strong community connections. We partner with the Foundation for Healthcare Quality around understanding birthing outcomes by race ethnicity. We also are working with the Asian Liver Center around hepatitis B and C education. And we've worked with Public Health Seattle King County, not only just like for the vaccine clinics during the pandemic, but we also sit in as part of the Pandemic and Racism Community Advisory Group. So so Microsoft has a commitment to community as well as to our employees. Thank you.
All right, thank you so much, Amy. I love the theme of community that came up so much in your presentation and in the others as well. And this moment, I'd love to invite our other speakers to come up. Beautiful. And a big thank you to all of you. Thank you for sharing your space and your ideas today. So I will just ask a question to kind of kick this off, and then we'll walk through the Q&A that our audience members have entered in. So just in thinking about the biggest facilitators for change you've had, we've talked about, factors like shifting power, building trust in data that often doesn't come with that sense of trust. And we're curious, kind of as we think about in our own organizations, how to build a more equitable healthcare ecosystem, what kind of facilitates addressing those barriers? And Amy, why don't we'll start with you.
So when you think of ecosystem, I'm gonna ask you a question. Like when you're talking about ecosystem, could you be a little bit more specific?
Yeah, so just all the factors involved in sort of the delivery of healthcare. So Microsoft as a purchaser of healthcare, health plans paying for those services, HCA as a purchaser, that's all the players who touch the delivery.
Yeah, sure. Well, I think that one of the things that's really helpful is to understand like what are those levels of data that we want to capture. So like when we're talking about like the SOGI data, for example, the sexual orientation and gender identity, like how is that being captured? Or race ethnicity, because the federal government has specific standards. They have the Office of Management and Budget, and sometimes they have 5 categories, and they may have the 9 categories. And really in Microsoft, for example, like we would really like much more detailed information because our population is so diverse. And if you don't have the data and you can't be able to look at it, it makes it really challenging to design those programs and services or really understand like what your outcomes are. So like having alignment across like the types of data that you're collecting and even some of the definitions, because like if you're looking at your HEDIS measures versus like your CMS, so like all the different ways that you can measure these outcomes, like sometimes there can be challenges in understanding or agreement upon like how those definitions are being made. So I think that's one of the elements. And then looking for those places for alignment, like again, like if there is an opportunity for that connection, but a private entity is limited by something at the federal government, like how do we figure out how to educate or advocate for a change in a way that can allow us to meet our people where we need to be.
Thank you. That's perfect. And Dr. Young, how about you?
I think when we've thought about sort of facilitating this process, a lot of it goes back to just really, really getting some foundational understanding what's happening. You know, I think having been a practicing physician for a long time, I think part of that medical training goes into feeling like, oh, we have the answers, we understand what the issues are, and that we just need to help other people understand what the issues are and what they need to do. And I feel like actually what facilitates the process at this point is to really take a step back and say, okay, we assume that the communities that we're working to support and collaborate with all want the same things, that everybody is seeking to have good care, good health for themselves and for their families. And that if they're not doing things on the surface that seem to be things that contribute to their health, it's not because they don't want to or they don't understand the importance. It's that there's something in the way, and that it's actually up to us, those designers of the systems, to go out and get that understanding of what is getting in the way. And when we've stopped and done focus groups and had conversations, we have learned so much, because there were all sorts of, what we learned was that, you know, there were all manners of assumptions being made. So I believe that a key part of the facilitation is, or the facilitators, is to have those real conversations. But in order to do that, you have to build that trust, you have to build that safe environment in order to have those conversations. And we, in the organizations that inherently currently have more of that power, have to recognize that that is a dynamic that exists. And we have to have the humility to stand back and listen before wanting to leap to making immediate programs or plans or anything else. We need to take the time to listen, which, you know, back to Dr. Huynh's point earlier, like, this is going to take time to do. And we will work as quickly as we can within that, but we also can't rush this beyond what is needed right now, because we have to get it right.
Yeah, and I love the word humility. I think that's a beautiful term to think about as we move through these ideas.
I really like how you're framing kind of the conversation around what we bring to the table versus how we engage the people that we are trying to serve. And, you know, I think that it's going to be an interesting dynamic, right? There are, I think, increasing external requirements that help define how we do this work, which I think is really great in a way, right? Because it's really elevating this in organizational priorities. But determining the rules of the game, or even determining the rules of measurement, has a major impact on what we actually decide to do, and that may or may not be actually what community would like to prioritize. So I think it'll be an interesting journey to see how we balance kind of the voice of community with what all of, you know, the various and sundry external requirements, all well-meaning and probably and hopefully all impactful, with the things that the people that we serve are telling us they want.
Dr. Huynh, I'm going to bring you in on this conversation as well. There's a question that was prompted in the Q&A box that I feel like touches upon this topic, where an individual is saying they really appreciated the comments you were making about power shifting. And they would love to hear from you or any of the panelists about strategies we can use to broach the challenging space of power redistribution. So there's a lot of barriers within that area and a lot of difficult work to be done, but what are you seeing in your role? And if others have other input as well.
Oh my goodness, that is such a big question, right? Like, if I have the perfect answer for that, I think I would have solved everything by now. I joke, but I think that it comes from multiple different angles and levels. In order to address that issue, we have to be able to look at power and recognize that who holds power and where is the power supposed to be in order for us to achieve the result that we want to achieve. If our goal is equitable access to care and really health equity for all of Washington state, then it shouldn't just be, you know, government that holds that power or MCOs that hold that power. It really needs to come from the communities and the people that we serve. And they inherently they have the power because they themselves know what is needed for their communities, for themselves. And what happens is that we as government, MCOs, other entities, healthcare institutions, we need to get out of the way of that. What we need to do is we need to bring in the tools, and we need to support these communities and the people so that they can elevate their health in a way that is going to be most successful for them. Sometimes in our work in government and whatnot, we become the barrier, and that's an issue. And then we hold that power because we are now the roadblock, right? So that's one way, really looking at letting the communities be that power holder. But then the other side of it is we need to educate our own agency, our own government, because until we recognize that we are the ones that hold those powers, a lot of times we take that and we become the barrier. If we don't recognize that we can't create a new, a change in the infrastructure, this is going to be a lengthy journey, and it's going to be kind of what I think about like a seashell, where you kind of go round and round, and sometimes you feel like you're getting closer, but then you're further again and then closer again. And it's very much like that. And this is a journey, and it's going to be a lot of trials and errors. There's not going to be a perfect answer. But I really like Dr. Young's comment about humility. If we come at this work with humility, being willing to say, I don't know the answer to everything, can we work together? That is going to be a really good start to this and building that trust with the communities and the people we serve.
Seeing if there's other panelists that may want to touch upon that, or there's going further with that, there's a question in the chat though saying, have you encountered issues with trust and respect on part of those you are serving? So when you're trying to do that power shift, and with the history that may exist with those communities, how are you working on addressing those and building that up?
Yeah, I mean, for sure. We've had trust issues with the community that we serve, and we've had trust issues with our own employees, and those trust issues are completely earned. You know, we've participated in structural racism and other inequities for all of our existence, and it will take work and sustained work to demonstrate that we're going to do things differently. And I'm still not sure. I'm not sure that we're going to do it. I hope we do though.
I'll also add, because a lot of us on here are clinicians, medical providers, and I think of building this trust with the people we serve is kind of like this really ugly wound that we have, and we put a Band-Aid after Band-Aid after Band-Aid on it, and we like come up with these programs and services. And we're like, yeah, this is going to solve the issue, when they're just more Band-Aids. What we need to do is we need to rip those Band-Aids out and look at that really festering wound. It's going to hurt initially. And so the beginning of this work for any organization or agency, I think that the mistrust is going to come forward. And it's going to be very apparent with those initial steps, because that's the rip off the Band-Aid stage. It's going to hurt a lot. And so we're going to be able to highlight a lot of the disparities, a lot of the mistrust. But when we're able to see that, I see that as a step forward rather than a step backward, because before that, maybe we didn't even know that there was mistrust. Maybe we didn't even have a way to communicate that mistrust, and now we can. So at HCA, we recently started a community advisory team. And on that team, there are over 20 members that are able to attend. And some of the community members that came in were just like, you really want my voice? And it's like, yes, we do. We cannot promise that your voice will translate to concrete solution immediately. But yes, we do want to hear from you. And the first things they say is, I don't trust you. Well, they didn't have a chance to say they didn't trust us before that. So it's okay to hear that there's a lack of trust, because then we can move forward from there.
Yeah, and I think part of this conversation too is, I think it's important to acknowledge that, you know, it's going to take time for us to take in this information. We need to listen, but there is an urgency to this as well, because even if we're doing this in incremental steps, we very quickly are going to need to come back with, okay, this is how far we've gotten. because otherwise it's not fair. I mean, it's, you know, it's been acknowledged before, there is a burden placed upon those who've already been experiencing all of these barriers to, let me take from you some more, let me take from you your thoughts, but I'm not going to give you anything in return yet, because it's going to be a long time before we can do something. And so that's been part of how we're looking at it too. It's, so we're going to ask the questions, we're going to lay out up front why we need this information, how we're going to use it, but then as quickly as we can, coming back with how we are using it and how it may have a positive impact. And part of it too is internally supporting our own people through this process, because everybody is in a journey on this, you know, regardless of your own, how you identify yourself, your own race, your own ethnicity, we are all on a part of this journey and we're at different points in it. And this is emotionally taxing for everybody involved. And I think to have that compassion for each other, to learn and understand. And if we don't have that support, then it'll be easy to kind of revert to the way things have always been. And that's going to be the sustainability of this effort is probably one of our greatest challenges. And so the more that we can support each other around it too is extremely helpful. But I think on an organizational level, that's important.
Can I just add one more thing to that in regards to the trust piece is really that workforce piece. And I'm talking about workforce both for us, the internal workforce at HCA, which is we serve some very diverse and very underserved, underrepresented, and disenfranchised populations who also happen to be very resilient populations, right? And we need to make sure that the people that work with and in our agencies represent those communities we serve. That is one way to build that bridge and to build that trust. Those with lived experiences know how to solve the issues compared to those who just come in at it from a textbook viewpoint. And then building workforce internally, but then also building workforce for the healthcare workforce in Washington state too. We need our healthcare system, our providers, clinicians, different levels of community workers to represent those communities, because then they can be that bridge and they can be that voice, and then that will help us build the trust too. So just to be, you know, to bring it to a more concrete answer, it's not always like, oh, this is so sad, we're never going to get there, and that's not really my my point, but it's like to have that patience, but then also hurry up and let's get this going with some concrete strategy. So it's a balance of let's do this now, but let's also have patience.
Yeah, I mean, I think it's so true that there's only so much you can do to bridge trust when there's nobody that looks like who you're trying to bridge the trust with, right? And who doesn't know what that experience is. You know, no matter how well-crafted your mandatory training is, it's not going to bridge that gap to really understanding the lived experience of somebody who's completely different and who's impacted by these inequities. And so, you know, I think that I think there's still active questions around like what can we do with the collective power we have, whether governmental, large provider system, payer, large employer, to really identify some of these levers that we could potentially have collective impact on, right? Whether it's up, you know, how far upstream can we get in the pipeline for healthcare workers, you know, and how can we have shared prioritization of what that looks like in this state? You know, what would it look like even from a policy perspective to or professional organization perspective to help push the envelope on who actually even gets licensed, or who you know, some of these structural barriers. I mean, I remember, I'm sorry, this is not intended to be individual soapboxing, but like, it's something that comes to mind is the disparities for the NASW, so the social work licensure, in the pass rates for licensure for people of color versus not, right? For an organization that's creating a workforce that's about addressing social, you know, needs, right? And who, you know, are a lot of the backbone of our behavioral health workforce, right? How do we collectively get to addressing some of these inequities? I mean, if the social work licensure things look bad, we know that the medical ones look worse.
Yeah, thank you for raising that. We're nearing the end of our time. I had one more question for the panelists to hopefully add a little more positivity is what is something that maybe a specific initiative that you have done within your organization that you're really excited about and proud of that you would like to highlight? And then if you can touch upon it, there's a couple resources each of you spoke on during your presentation. If you could let the audience know where they could access that, like the Health Equity Kit, please let us know, but I'll let you each speak to those.
I know our time is limited, so I won't speak on it too much, but I think what we're most proud of at Premera over the last several years is all of the investments that we've made in the community through our social impact grants, because we recognize that in order to advance anything in health equity, it needs to be community-based. It needs to be really championed and geared by the communities that we're trying to support and help. And so it's really helping to build some of that infrastructure, whether it's helping on an educational standpoint to have make it possible for more members from communities of color to be in the healthcare workforce, whether it's helping local agencies be able to do more for their members, but from an infrastructure standpoint, not just program delivery, but that's really where we've been putting a lot of our efforts in the most recent years.
I'll add that at HCA, we have so many initiatives and so many things happening, but I think one of the key things that has made it possible is that creation of the health equity liaisons, that they become sort of the web that have influence and involvement in all of our 18 internal divisions, because we have 18 divisions that do a lot of different work. And so having these liaisons help to connect all the different parts of the agency so that we're not so siloed in our equity work. And then the creation of the pro-equity anti-racism teams and the community advisory team, because they're really impactful in the way that getting those community voices to help us change, make some very concrete, specific change to our services and programs. So those are two areas that I am really excited about for HCA in the last couple of years, and moving forward. We've got some strategic plans that's going to keep us moving and changing that culture, because we can't move strategies without changing the culture. So excited about that.
Amy, do you want to go? And then we'll end with Joe.
Yeah, I can go. I will say that, so I'm relatively new to Microsoft, so I may not hit on all of the high points that Microsoft has done, but I know that one of the areas that was a big highlight was actually around like the community vaccine clinic, which was hosted here. And there was a decision, a very deliberate decision that community got to go first rather than employees. And so that was a big effort. And I'd say like the role that I have here is also new and trying to develop more around our evaluation and research. And so that's another item that I think we're very excited towards. And we have a couple of plans and that are in place that really connecting up with our employee resource groups to be able to drive some of the outcomes and interest in hearing back from those groups about where we should be investing. Thank you.
Yeah, I think we're really excited about the work that's launched to, in particular, the work around engaging our own people and the work around engaging our community, and the significant investments in workflow and data gathering that will help, I think, be the backbone for thinking about how we do things in a different way. But again, like I think we've all been saying, there's so much more work to be done to sustainably demonstrate that we actually mean it and that we are going to do things differently.
Thank you all so much. I have one more thing to share with everyone. So thank you everybody for joining us today. We just wanted to highlight there are a couple other events going on that we hope that you were able to join us for. On April 12th, we at the Foundation Healthcare Quality are hosting another webinar that's focused on our climate's impact on health. This will be from 12 to 1:30 p.m. and Nick kindly put the link to sign up for that webinar in the chat box. We will have our second webinar, we're part of this series, on June 1st from 12 to 1:30 p.m. You heard our presenters speak a little bit about how data can be very complex, but it's necessary in our work to understand or provide more information on what's going on within those community levels and what we are seeing. So we're going to explore the complexities of that data at our next webinar. And that, again, is on June 1st. And then at the Foundation for Healthcare Quality, we are creating a health equity action collaborative. So if you or someone at your organization is interested in taking a health topic and implementing that into practice to uplift the healthcare quality for a certain population or that health topic of your choice, please connect with us via the BRE email so we can provide you with further information on that event. We're hoping to start that collaborative in May. So we will let you go. I think, Drew, I saw your hand raised. If you had a comment, go ahead.
You know, I didn't have a comment. I just wanted to say thank you for the presenters for all your work, and look forward to having the next discussion.
Yeah. Thank you. Thanks to each of you for providing us with your time. We really appreciated the opportunity from hearing from you.
Thank you.
Thanks, Bethany.
Thank you.